Hi everybody, I'm Laura Schmidt from the Impact Program, and I'm here to I want to welcome you to our final set of speakers for today's event. And I'm happy and honored to introduce you to three key leaders whose job it is to fund and steer research that protects the health of our community. These three individuals sit in positions of leadership in academia, government, and private philanthropy, respectively. And I've asked them to share how their institutions are adapting to the changes in the federal health priorities and to suggest strategic ways that we can come together to protect the health of our community. So our first speaker is Hal Collard, and Hal serves as Vice Chancellor for Research here at UCSF. Since January, Hal has been central to the university's frontline response to the federal funding cuts and changing NIH priorities, a response that has so far required direct advocacy in Washington and in Sacramento. He's been doing a lot of flights, and I think he's got one tomorrow, as well as a considerable amount of class action litigation that I think we've heard quite a bit about throughout the day. Hal's a Bay Area native, and he has deep roots in this community. He's a devoted clinician who specializes in treating patients with interstitial lung disease. And he's a very accomplished clinical trialist. Hal's also got specialty training in health policy and law, which I'm sure is coming in handy these days as he steers us through today's troubled waters. So please welcome Hal Collard.
Can you hear me with this? Yeah, great. I'm going to stand over here. Avoid the podium. Thank you. That was really nice. Thanks. It's great to be here. A couple of words just up front. This is such a terrific conference. Thank you to the organizers for structuring it this way, and thank you to all of you who are our partners in the community for being here. It's really meaningful to me, to us. I really center and value this type of work. I come from this type of work. So I stand up here as a representative of the institution in an institutional leadership position, but my roots are really with all of you, and I feel at home. So it's nice to be here, and the discussion today has been great. I have my phone out because I have my notes on it, not because I'm checking the scores or anything here. So I don't know, is there any games on right now? A couple of things. So first, this is not, I'm Vice Chancellor for Research, as Laura said, so I'm going to speak really predominantly about research and the current situation, particularly with the federal government. I can't really speak to the health system or public health. Luckily, we have others, on stage and here who can speak to that. But my comments are really going to be about what's going on with research right now, particularly in response to the federal government's actions over the last year or so. So I want to tell you a story to start. Some of you have heard this story before. It's a bit of history. In 1945, there was really a seminal publication report made to the President of the United States about the future of research and what the government's role should be in it. This was called Science, I think The Endless Frontier was the name of it. It sounds like a novel or a Star Trek episode, but it was a report to the president, and it was commissioned by FDR in 1944, really in response to recognizing the importance of science to the public good. And in 1945, that argument was made, I think, very strongly. I encourage all of you, if you haven't read that, to take a look at it. It's very easy to read. It's relatively short. It has a nice summary up front. It makes the case really well for science, the pursuit of knowledge as of benefit to society. And there was a decision to make that year in 1945, Harry Truman faced, which was, how do we implement this vision? Do we implement this vision internally, internal to the government, or externally? And the two models really were a university-based model or a government-run model. And there was a lot of discussion about which model was best. And the extramural university-based model won out, and that is, as they say then, history, right? Then there was this tremendous investment over the next several decades in infrastructure and research support from the federal government, and that has allowed us to develop most of what we have today in the academic biomedical space. I think what I see happening today is a revisiting of that question of should the government fund research externally in a university-based system where knowledge, the pursuit of knowledge primarily drives investment. The coin of the realm is knowledge, is new knowledge. Or should it be a government-based, or let's say internally based system where I'm going to use the word impact, which I think is a positive word, but in this case I think is problematic, where impact is the metric, and impact as defined by the political voice of the day. I think that to me is the key. Impact defined by people in power who have a very high central role in funding, but not the people who are doing the work and who are asking the key questions like we're talking about today. So I think that's what we're seeing. When I look at what's happening in DC, I think this is an actual debate about how should the federal government structure its support for science. I'm less concerned about the amount of money that NIH is going to get. If you look at what's recently transpired in Congress, we continue to have strong support from Congress for NIH funding. And Congress sets the budget for NIH. Yes, there are a lot of concerns about workarounds, but I feel fairly confident that we're going to have dollars there. The question is, how are they going to be administered? Right? Are they going to be administered in the way that we're used to, where all of us get to ask the question, and based on its scientific value, its potential to contribute to knowledge, we receive funding, or are we going to have to match priorities of a central administration that is then giving out funding? We have models. It's not a bad model. It works for. I mean, there are foundations, for example, that there are lots of examples of places that have priorities and fund those priorities. That's important too. But as our core source of support, that is overwhelmingly kind of financially our source of support, we have to. I believe we have to have a broad and knowledge-based vision for that. So I ask you to think about that and tell me if you agree with me that that's really what we're dealing with. So I think it's not that this is, this administration may be an aberration, it may be a blip, as one of our debate students was saying, but I think the question is going to persist. And I think it's because of what a lot of us have talked about here today, that the social contract, the agreement between, let's say, academia and its partners, research, knowledge-based research, and society has broken down. This is, a number of people have said this today. I think it applies in a very local sense, it applies in a national sense. Most of America doesn't appreciate or see the impact of science in their lives today. At least a lot of science. Biomedical science may have a leg up there because it ties to medicine, and people, usually most of us have a story about somebody, of course, that we love, impacted by illness, and can kind of see the tie between, at least research tied to that illness. But for a lot of science, the relevance is not there. So what do we do about that? I want to make a couple of comments of how this is manifesting and then talk about what we do about it. I think you all probably know the answer about what we do about it. Okay, so what's happening right now then as a manifestation of this? A couple of things. The first thing was a proposal to the NIH budget and many other federal agency budgets to significantly reduce the amount of money for fiscal year 26, which starts in October. As I just mentioned, that doesn't seem likely because Congress, now both the House and the Senate, have basically put forward proposals for level funding of NIH, $48 billion a year. So that's great news. That's not final, of course needs to be signed, there's lots of, but that I think is not going to be where we see persistent challenges. There is a lot going on in the agencies, particularly NIH, about what is being funded, right? Many of you, we talked about terminated awards. We experienced over 100 terminated awards here at UCSF over the course of the last 6 months. Most of those have been reinstated thanks to the efforts of our legal colleagues, thanks to the efforts of our colleagues like Nita, who was up here earlier, and effective arguments in court that these were illegal actions. Whether those stand up long term, we don't know, but they're standing up for now. And but that's another way we're seeing it manifest, right? That is a very direct reflection of a priority-driven, a central priority, impact-driven approach to funding science, right? We know what we value, we're going to fund that. We're seeing this manifest in questioning the amount of money that universities get to support their research activities. This is what the indirect or facilities and administration debate is about, if you're aware of that. It's kind of a bit esoteric, but very important to universities. It's essentially overhead. We receive, as we again heard this morning, we receive at universities generally more overhead per dollar than, is that my phone going off? Yeah, sorry. Hi, Mom? Yeah. We receive more money per dollar than other partners. Why is that? Well, because overall our overhead for high complexity research, laboratory-based research, computational research that requires large compute access is very expensive, and so there's this transparent but complex way in which this is calculated. This is long been, it's a problem that it's complex. It's long been a point of contention for a number of members in Congress, and it's quite possible that we'll see a reduction to that in the next year. That's going to have a big impact on, just to let you know, at UCSF, we receive, that has a potential to have a, let me count the number of figures, basically $100 million or more impact on our research budget a year. That's why we're seeing so many institutions making so many changes and being so nervous about what's happening, separate from the individual actions that we see against some campuses. So that's how we're seeing things manifest. We're seeing, questioning of the overall funding of science. Luckily, we still have strong support in Congress for that, and I think that won't be successful. We see a lot of efforts to terminate and direct grants towards specific priorities. For the time being, we've made progress on that, but that could reverse, and I think we'll see what happens in the next couple of months around that. And then we're seeing these questioning of funding of institutions like universities that really do rely on this additional funding to maintain the research that we do. So there are a number of areas the word attack is coming to mind. I don't want to call it that. Number of areas of concern and challenge for us, let's say, in continuing to do and support and finance the type of research we want. So what can we do? And I'll just end here, and maybe we'll talk about this more as a panel. I think today has been exactly like the medicine and the solution we need. I think the fundamental issue here is the loss of the connection between science and society. We have not done a good job of explaining the relevance of science to people in our community. It is our job to do that. How do we do that? Well, by partnering with community members in the first place so that we understand what's important. They have an opportunity and to contribute, to truly partner, and to feel ownership of the work we're doing. And through that, naturally, I think, comes support. So when we vote for people, when we talk to our elected officials about what's important to us, this is what comes up. I guarantee you, if the constituents of the leadership in Congress right now were making a fuss about this to them, saying this is not okay, you need to fund, this would not be happening, because that's what politicians do. They represent the views of their community. Yes, the administration or others, there can be variance around that, but I feel very strongly that that's what we need. We need all of us to understand the impact of science and to communicate that to our elected officials and others who make these decisions. And that will be our way out of this. And I think that the last point I'll make is I think it's really important, at least to me, that we keep the focus on science being, and funding for science being the value of it being measured by the contribution to knowledge. Knowledge translates into impact. Knowledge is where you can't pick winners in science. So knowledge is where the unexpected breakthrough is going to come that then is going to translate into major impacts like the mRNA vaccine, like CRISPR, like things that we've mentioned earlier today. So I hope we'll have a chance to talk about that more. I really want to charge each of you to think deeply about how can we together, this is like the choir here, right? Like we all believe in community-based research. How can we expand that to really bring all of science into this dialogue and then help science be more relevant and ultimately reestablish that social contract? Thank you.
Thanks. I think things seem so arbitrary and chaotic that I hadn't really thought that there was maybe a conversation going on behind all of that around what is the role of the federal government in funding science. And that's an interesting take. So our next speaker is coming from the governmental side. It's Dan Tsai, and he directs the Department of Health for the City and County of San Francisco. And throughout his career, Dan has worked tirelessly to protect the health coverage and services for underserved communities, especially kids, lower income families, and disabled populations. Dan has worked at all levels of government. He ran Medicaid for the state of Massachusetts. He was at the federal level. He was appointed by President Biden to oversee Medicaid and the Children's Health Insurance Program and worked there for about 4 years. And these are programs that today, as we all know, are acutely threatened by legislative cuts. So now Dan runs one of the largest city health departments in the country and can help our local government in responding to federal policy changes. So please welcome Dan Tsai.
Thank you. Can I just sit here and chat? So it's lovely to be here with you all. I thought I would, I just passed 6 months in my current role, so I'm probably one of the newest people here in this room to this community. But I've loved being here in San Francisco and at DPH, the only DPH in the country. I mean, San Francisco is a very proud place with a lot of history and heritage in the Department of Public Health, and that's part of why it's so exciting to be here. When I was with Susan Ehrlich, who's the CEO of San Francisco General, and one of my many visits and tours for services and programs at the General, we were looking at some of the original posters and ads for early days of HIV/AIDS work, and you see smattered everywhere, whether it's here or broader than San Francisco, funded by the San Francisco Department of Public Health, and it's a pretty cool legacy to be a part of. And it's a department that has a lot of amazing people and mission-driven folks, and we provide both amazing care, and we're really unique anywhere in the country because we are both a city and a county here in San Francisco, which means we are the safety net provider in partnership with UCSF on a lot of our clinical work. We are the mental health and substance use disorder authority of the county. We do full population health and classic public health, including inspecting restaurants and things of that sort. And because we're in California, one unique piece about California is so many of the things that are typically done at the state level. So in Massachusetts, many of the things we do here in the department were things that we just had at the state. There was no county-based system. And so what you have as a result in San Francisco is a 7x7 square of 800-some thousand odd people with a huge safety net presence, with everything kind of aligned department-wise in one place. 90% of our health plan lives in Medicaid are through the San Francisco Health Plan. And in a city and county like San Francisco that has historically been tremendously resourced. And so that's why I said, yeah, this is kind of interesting as the next thing to do. And the other part was, looking at the quality of the assets in the department, not only the general and also the relationship with UCSF, but so much of what happens across what we do kind of in leading innovative ways. And so I get to take credit for all the stuff that happens in the department now, but there's an incredible amount of stuff. So I love being here, and I thought what I would say, cover is just a little bit of a view of where we're going as a department, some of the federal pressures ahead, and a little bit of a push and pull for this group with respect to kind of the set of folks convened here in this room. But so at the department level, our mission and vision, our vision for the Department of Public Health has been to make San Francisco the healthiest place on earth. I think that's a pretty cool vision when you see it. Wow, let's go bold. Now, it turns out, as I've been discussing with our team and in many different groups and staff meetings all across the department, we are very, very healthy in San Francisco overall, and we're a very wealthy city, which hence very many resources across city and county government. But we're not healthy for all folks, and we have substantial health disparities when you drill down, and that's on a whole number of dimensions. That's on mortality across a range of chronic diseases, as well as for overdoses. Overdose is the #2 cause of mortality in the city, and Black African Americans die at 5.5 times the rate as the general population. Numbers 1, 3, 4, and 5 are some form of cardiovascular disease, and you also see a huge disparity there. We also have tremendous disparities at the very beginning of life for preterm birth rates, for example. And so the three main things I think of for the department: number one, going upstream, how do we pick a handful of areas, chronic diseases and the like, where we set a goal over 10 to 20 years of getting to zero on eradicating those health disparities. So that HIV and now Hep C concept that has been essentially born here in San Francisco, and figuring out how we go way upstream, even to stuff that the department doesn't control at all, to really tackle a finite set of those conditions, and to think about how we organize parts of the city, the community, and to figure out what types of interventions will actually work and have a chance in a scalable way at closing some of those disparities. And so that's the first goal, and that's kind of to be honest, the most nebulous. I mean, I think it's exciting when I chat with staff and hear their excitement around this. And we've done in public health many things all across the country to try to get at health and health disparities, and it's very elusive to figure out what are the right interventions, how far upstream to go. Certainly, we've been thinking more around nutrition and housing and things of that sort, but some of these things go way, way upstream from that. And I get excited thinking about what is the next thing we as an entire community can chart together for what is the San Francisco way of trying to demonstrate how we as a community come together beyond just the assets of one department or one set of CBOs or one institution like UCSF, et cetera, to really tackle this and to show what we can do. The second is for us to be the best healthcare delivery system in the world, public or private. And I start from the point of view of us in the department being a provider, where we provide amazing care when folks come in front of us in partnership with UCSF at the General, where our MD staffing is with UCSF. But we have a long way to go relative to really having integrated population-based care, meaning we take great care of you when you come and show up in front of us. In whatever state of crisis or need, our team, our clinicians will do everything under the sun to care for someone until you next show up at our clinic. What we don't do as well is longitudinally following folks and being able to think about the ways to organize healthcare to keep folks healthy, or to prevent escalation of risk, or to really sometimes get outside of our four walls, or to have the hospital, primary care, specialty, behavioral health care all work much more seamlessly. And who is on first when we have some of our most complex individuals hitting all of the different parts of the city system and other providers? we do not do a good job both within the department and across the city when you look at DPH and other providers and really organizing how our delivery system should be structured in a way that helps people successfully move through whatever clinical journey of health that they're on. Part of being the best healthcare delivery system in the world also, when you think about things from an equity standpoint, is access. And there are certain parts of the city that I've now gotten substantial education on, including in the Bayview in some of the Hope SF sites in Sunnydale, for example, where the percent of our technically our patients, but the number of those folks that are actually engaged or seeing our primary care, very, very low. For a whole ton of structural reasons, that presents an opportunity for us to think in very different ways. So that's number two. Number three is tackling the behavioral health and homelessness crisis, of which so much of that is finding a more proactive way to think about a system of behavioral health care that quickly, when someone is willing to raise their hand for any sort of treatment, mental health, substance use disorder co-occurring, we can roll out the red carpet and quickly get people through an actual system with different levels of care, with structure, instead of a lot of the very well-intentioned but very disparate levels of care, settings, structures that we have. And just today, I was at one of our new crisis stabilization units, walking through and seeing how things were going. Incredible work at 822 Gary, crisis stabilization for folks in mental health SUD crisis. And one of the big challenges is, okay, when we have folks who want to go into treatment, well, some of our programs will only do intake at certain hours, Monday to Friday, and will not take folks. One person had repeated suicidal ideation, and the residential mental health provider said they're too complicated for us, take them back. And that I don't mean to be disparaging of our providers. We have mission-driven CBOs, but I think we can all agree that when those sorts of things happen, the structure of how we have organized things and what we're doing are not sufficiently serving the needs of folks that we are trying to serve in a way that actually makes sense. And so there's a ton of opportunity there. And so that's a little bit of the view of where we want to go. I think there's tremendous opportunity for even more partnership with the community, with CBOs, with how we actually listen and engage and shape the direction of the department together. And my push and pull a little bit, I'm going to skip the federal stuff and we'll come back to that through Q&A because I saw the 5-minute notice, is I think the push is when I look at the stuff we do across the department, where we fund a ton of CBOs in partnership doing on-the-ground care, we have tons of NIH and other federal grants where we do a tremendous amount of research. We have partnerships between UCSF and our DPH team in our different care settings doing research. I also see a plethora of contracts where sometimes we haven't intellectually interrogated enough how and why we are doing things. What are the outcomes, what's working, what's not working, and how do we make difficult decisions to decide where to invest resources. That's both budget-wise, people-wise, data-wise, capability-wise, and I think there's much more opportunity for that. And the pull is, I think as we try to tackle things like going really far upstream on health disparities, or we try to have much more culturally congruent work with our CBO partners and supporting the health and immediate, say, even overdoses in the community, I think we have more opportunity to take a look at data, to have CBOs and others help partner and shape through what folks know on the ground of what actually works and what doesn't work, and to think about scaling those. So that's all tremendous opportunity, and I think for time, I will stop there and pass it on.
Okay, our final speaker representing the philanthropic sector is Dr. Erin Hagan. Erin is the Deputy Director of Evidence to Action at the Robert Wood Johnson Foundation. RWJ is our country's largest funder, philanthropic funder of community-engaged research. And over many decades, the foundation has been pretty steadfast in its commitment to building health equity by changing the environments where people live. Erin's program and the foundation have been particularly noteworthy in their response to the changing federal health priorities this year, For example, they rolled out a rapid response program that is reinvesting in racial and indigenous health equity research and really making them a model. I think, yeah, really making them a model for strategic philanthropy. So please welcome Erin.
Thanks, Laura. Thanks, Laura. Thank you both for providing your introductory comments. I want to talk a little bit about the Foundation's work, and particularly how it has evolved in terms of how we think about community in the research context, and particularly from the perspective of E4A, and then I will talk a little bit about our rapid response funding that is available. First of all, I also just want to commend the Foundation for being among the very small group of private funders that are really pushing back against the federal government, doubling down on their efforts to continue to support racial and indigenous health equity in the face of these, I will say, attacks from the federal government. And so I am really bolstered by their continued focus, both in their communications and in the funding that they're making available to specifically dismantling racism in the United States, dismantling colonial structures that have invaded our systems, and to advancing racial and indigenous health equity. And I think that's incredibly important, and that means that both what they're doing, like the amount of money that they're putting out, and the way that they're talking about their work, but also the way that they are doing their work internally has shifted. So there's both an internal and an external differences in the way that that work is happening. One of the main systems transformations that the Foundation has been focusing on, or has started to focus on, is transforming the health science knowledge system. This is a term that they coined, and it basically just means the systems that operate in the production of knowledge. And so that sort of encompasses the academic institutions, major health research funders, and also the publishing and editing institutions that share this research with the world. And a few years ago, so Evidence for Action is a research funding program of the Foundation. We focus primarily on solutions-oriented, action-oriented research, and most of what we fund is social science-oriented research. So we don't fund biomedical or bench science of that sort. But a few years ago, we had focused primarily on causal inference style research, and we started talking about what does action-oriented research mean, and the fact that our action orientation is really what made Evidence for Action unique and made us different from other funding opportunities, inclusive of what the NIH was funding at the time. And we really acknowledged that there is a wide range of research that supports action and implementation and impact, and that our portfolio was very narrow and not encompassing that entire range of research that could support action. And I guess I should mention that my own background, I do have a PhD, I'm trained in methods, but my own background prior to coming to run this program was in advocacy and even some lobbying, and so for decades of my career prior to this, I worked in more advocacy settings, and so that was also quite of interest to me personally, to be doing more action-oriented research and expanding the sort of research that we were doing, and funding, I should say, really. So we embarked on this effort, which we called the Ways of Knowing tour, or symposia, and we hosted a number of town hall-like meetings around the country, focused on different topics. Indigenous ways of knowing was the first focus area, transforming community-led research was the second, and redefining rigor in health equity research was the third. And these were town hall meetings, I say, because we went to listen to people who had been doing this work for decades, to hear them say, what do you need? How do you need the system to change in order to better support the work that you're doing? And one of the things that I felt was so poignant coming out of those meetings, across all three of them, even though they were sort of different areas and all with different people, was this sense that science had become a tool for invalidating people's experiences in the world. So you would come into a community, and so people would show up and say, well, what has your experience been? And people might say, I feel like we're totally over-policed. We're being surveilled at every turn. And then researchers would say, let us do a study to see if that's true. And so where we are really trying to push at this point, right, is you don't need to do a study to see if that's true. What people are telling you is true. It is valid. Their experience is true and valid. And then where you can be of use as a researcher is in service of a solution to that problem that people have identified. And also, by the way, people probably have solutions already in mind. So what you can do with your unique skill set as a researcher is to help evaluate whether that solution is really working and to help bring systematic ways of gathering information to understand if these solutions are working. And you know, I feel like we have often, so RWJF is a national funder and we fund all across the country, and many universities and research think tanks, especially large research institutions, work across the country. And so sometimes community has become this amorphous term. It just means like people who aren't part of the academy or people who, you know, it doesn't mean something specific. And we really also have to move away from that. And so I want to talk a little bit about some of the ways in which we've done that more purposefully with our funding, and also to say that what we're ultimately trying to support at the foundation is authentic research and community partnerships, and that we are really holding to this value that research is a tool in service of community priorities and community needs. And so even the term community engaged research feels backwards to me, right? Like it should be the community engaging research as a tool among the things that we have at our disposal to improve our lives. And so we aren't saying that we're swinging to community exclusive, right? That there's no role for researchers or academic institutions in those spaces. There is still that role. People are trained with specific skill sets that are valuable from an empirical research perspective, and when we use community in these amorphous ways, then we also, on the other side, start to discount sometimes the skill sets that researchers can bring, which we also don't want to do. I had just a quick aside, like a personal story. I have a friend, and we were having this discussion about the value of researchers' skill sets that they still bring, and he was like, well, but the community has those skills. And I was like, okay, in this like amalgamous idea of community, yes, absolutely, they have those skills. But in a very specific community context, like I live in a neighborhood and I needed a plumber, and none of my neighbors are plumbers, and I had to call someone and say, can you, I don't have that skill set. And I needed someone to come and do that work in my house. And I live in Wailua, which is a small town on the North Shore of Oahu. And the person who came to do my plumbing came from Diamond Head, which is about an hour from where I live on Oahu. And that was great. And I was really thrilled that he brought this specific skill set that he had to address my plumbing problem. But had he come and just showed up in my house and started tinkering around without me saying, hey, by the way, it's the shower that's leaking that I need you to replace the pipes for. Like, so my point was, in my discussion with my friend, there is this relational aspect, and it really should be that there are still skill sets that are useful, that researchers bring, but again, it needs to be in response to what someone is asking for that they need. And so, just briefly to touch on some of the ways that we have shifted our funding. Again, it's both sort of an internal and an external shift. So from an internal perspective, it also means that when we're drafting calls for proposals, that those are based on what people really need. So I think our most illustrative example is a year and a half ago, maybe 2 years at this point, we released a call that was specifically about Indigenous-led solutions. And when we developed that call for proposals, it was a really much longer process than it typically takes us to write calls for proposals. We started by doing listening circles with Indigenous community members, peoples, and scholars from all over the country. Dozens of scholars and community members about how we should structure the call itself. What should we be funding? How should we be releasing the funding? What should the priorities be? What should the requirements be and the criteria? Then we seated a new review committee specifically for that call, all of whom were Indigenous scholars or community members, all of whom were Indigenous peoples, who also helped to write the call itself, who edited the call, and then reviewed the applications when they were submitted, and then made the final funding recommendations to the foundation. And that process took much longer, but it was so much, we learned so much during that time. The projects that were funded are probably very different than what would have been funded otherwise had we not gone through that approach. And we have incorporated much of what we learned through that process into our more typical funding process now. So our most recent call for proposals that just recently closed required, for the first time, community-based organizational leads. So universities and academic institutions and large research institutions could not serve as the lead organization. Now, community-based organizations are welcome to partner with those institutions, and unfortunately, it's not that the researchers themselves are not inherently bad actors, but unfortunately the institutions are not great partners. Their logistical, technical, financial systems are not set up to sort of honor the value that and the needs and the requirements of community-based organizations. So a big piece of the requirement for CBO leads was to put the power in from the standpoint of money in the hands of the community-based organizations, who then can contract with universities or independent researchers to, if they would like. And we required something which is new even for us. We're requiring social contracts as part of these new grants that we'll be issuing. And so those, unlike a typical contract, sort of outline a shared values. They have a description of the values that the research team shares, and a discussion about the power dynamics and the decision-making structure, and who ultimately gets to make decisions and how is power truly shared. So those grants are forthcoming. So there's only, I say this to say, I think that sometimes, which we also saw during COVID, in the midst of crisis, there is opportunity to do things differently. I know the foundation for sure, for years there have been things that we had asked to do, and it was just like, no, we absolutely can't do it that way. And then COVID came, and then suddenly, overnight, we could do things differently that we had never been able to do before. So a lot of people that I have worked with and learned from sort of hold that belief. One of the roles that I previously played was the manager and then director of government affairs for the San Francisco Public Utilities Commission prior to holding this position. And at the time, the idea was always never let a disaster go to waste, right? Like never let especially in a water department, people don't know it's not working until your water main breaks. And so when your water main breaks, that's an opportunity to help people understand how important the water infrastructure is. So I do think that this is an opportunity to find a silver lining in this situation for us to maybe reimagine how these systems could work, because our health data systems, some of which are disappearing, they were never optimized to do racial and indigenous equity research to begin with. They were never optimized for health equity research. And so now maybe we have the opportunity to build better systems and processes. So I'll stop there for now.
Thank you, Erin. I'm just going to ask one question, and then I want to open it up so that folks in the room can ask questions or make comments. And to this point about crisis creates opportunities, we're already starting to see a drift a little bit away from Washington, maybe with the RWJ reevaluating its strategy a little bit. Scott Wiener, our state senator, proposed a California Institute of Health this year as an alternative to maybe fund some of the kinds of research that are no longer as a high priority for the federal government. We have the Western State Vaccine Alliance, which is creating sort of a new structure for state-level guidelines around vaccinations. And so during the debate this morning, we kind of visited some of these topics, and we had some interesting comments and important comments about the pros and cons of this strategy. What about folks in red states that are being already underserved? Are they going to be more underserved? But I just generally want to open up the conversation of what do you guys all think about, especially in your particular sectors, about regrouping in ways to fund research, especially community engaged and equity research, in novel ways that are a little different from how we've been doing it with the federal government.
Yeah, I can start. I am such a huge proponent of collaboration. One of my dreams, actually, is that I work in philanthropy to sort of change the way philanthropy works. That's my personal aspiration. And I really would love to solve this problem of philanthropy asking people to compete for limited resources to solve the same problem. Like, you're asking people who are working to do the same thing to compete for small amounts of funding to do that work. And I really would, I spend a lot of time thinking about how does philanthropy operate better to stimulate collaboration. So these opportunities where states are coming together to do that kind of collaboration are really exciting to me. I am originally from rural Missouri, so I totally get the certain places could not fare as well, and certain people could not fare as well. And at the same time, when you're from those places, I'm not as worried. I'm actually not as worried that the people of Missouri are going to be so worse off than the people of California, because the people of Missouri are also gritty and innovative, and there are people in Missouri who are working for the same things as most of the people in this room. And by the way, there are people in California who are working for not the same things that we are too. So I just have to say, I think that local innovation is really promising, and I also have previously been part of a funder model called the Convergence Partnership, where a number of national funders came together to pool their resources to fund health equity research, and I think that was incredibly powerful as well. So I am a big proponent of collaboration, and I know the foundation is launching a new health equity research initiative in the coming year, and they also are really thinking about sort of a network model, and they're trying to be more creative about how do we stimulate collaboration. So I think it's a great way to also drive innovation, and so.
I think also one piece, not just research specific, but with HR 1 and what Congress and the President have signed, is effectively dismantling huge parts of the safety net. And so here in San Francisco, we've estimated that we will, just within the Department of Public Health, we will have several $100 million per year of federal Medicaid revenue that will simply disappear, and that it's unfathomable to figure out how to fill that gap. And so in that context, when the federal government is in this sort of posture, fundamentally, we need to be able to look to state partners and others to be able to help fill gaps in the safety net, which is incredibly important. And we also know that healthcare is very local, and what happens here in San Francisco and what happens in individual communities, both geographic communities and a whole range of communities, really you have to go as to the ground as possible. And I think one of the challenges we have often in government bureaucracy, whether it's at the federal level or the state level, or now here at the city and county level, is how to take finite budget structures where there's constantly a food fight and trying to figure out how to make it through the next budget cycle or deal with all these federal cuts, and how to fundamentally work with and empower communities, organizations that are closest to the communities that we are trying to serve from a healthcare standpoint. And even that first goal I mentioned of really tackling and eradicating a set of health disparities, that's not going to happen from just like the department doing stuff by ourselves. That will need to come from the community. And I think the department has some really exciting ways in which we not only fund but partner and listen to and support communities. But I think there's a long, long way to go. And often it's really hard to fit the federal budget, but not the federal, I'm not at the federal level anymore. Where am I? San Francisco, at the city and county level. Any government, bureaucracy, and structures with nimble support for folks closest to the ground don't always intersect well, but I think we, from a funding standpoint and a budget standpoint, need to make sure that we're able to do that with rigor, with structure, but in a way that further empowers communities. So I think that's, so I have both a push on what we are hoping our state partners do, and then internally a push for how we, with structure, with discipline, try to make sure that we get past some of these hurdles that are very true of how any sort of government works. Oh, you got a microphone.
Yeah, I'll just quickly, I guess I'd say a couple. I love the comment about, in every crisis there's an opportunity. That is so true. Things get shaken up, and some of the things that are shaken up, it's actually helpful, and you can rethink things. I guess I look at this, I don't think we want to move away from the federal government. I think we want to expand. I think we cannot, and I'm speaking from, again, academic research perspective, we cannot replace the federal government. We need to be all in on getting the federal funding, maximizing federal funding, and we need to think about expanding. We need to encourage our faculty and partners to look for other funding opportunities, to be creative, to collaborate. We need to push the state and local government to invest, even if the dollar amounts are quite lower, the quality and the commitment is the same and critical. And I think there are opportunities there. I am really encouraged that Senator Wiener is putting forward, has put forward a Bill 829, and there are iterations of that in conversation. I think that would be really important. But we can't give up on, and I know you're not saying give up on, but we really, we can't replace the federal government in funding our academic research, our knowledge-based research. We can't do it.
I wonder sometimes if some of that more locally based funding might lead to more responsiveness to the community, and that's another potential issue. Any questions or comments from the group? Saji, it's a long walk.
Hi, Lisa Thompson, UCSF, from a red state, now in a blue state. I wanted to ask a question. I had my funding not terminated, but suspended because I have a foreign subaward. And under the new NIH ruling, you could provide a supplement to the foreign and continue doing your human subjects research. I was 100 participants away from ending my 4-year trial, so it looks like I might get it. But the whole idea of this was that the supplement will go to the foreign entity, not going to the university with which the grant is affiliated. They want to run them separately because in the NOA it said something about they didn't trust that the money was being spent the way it should be spent. And so I'm just wondering, in this context here, is there discussion at NIH about doing that same thing which I think would streamline for the CBOs. You know, they get their money directly, and UCSF gets their money directly, and that way things can work a little faster. So it might be to the advantage of CBOs to have their budget go directly to them. But on the other hand, they have to compete. They have to apply at the same time and get approved at the same time, I believe. And then the other thing, of course, is the indirects, which would be a little funky. So I was just wondering if there's any discussion that you've heard about this idea of like splitting the grant into the community implementer and the academic institution here as they've been discussing for the foreign grants.
Yeah, thanks. That's a complicated question. I'll just say I think I have not heard a discussion about a domestic strategy similar to the foreign subaward strategy. But what I like about both is that I think it actually it empowers the partner to have an actually direct relationship with NIH as opposed to going through a subaward from the institution. I think that actually that makes sense to me. The challenge is for the foreign subawards, the transition as you experience, like it just paused and you didn't have a strategy for 6 months, and that has essentially stopped your research. And there's also more administrative burden for the agencies, for example, doing it that way. But I think it's a great idea. I think, again, if there would need to be, you know, if that was of value to the researchers, that messaging needs to get to the people who make those decisions.
There was someone,
I just want to quickly add on that point that the Robert Wood Johnson Foundation, for the first time ever under this more recent, where we call for proposals where we asked for a CBO lead, is willing to offer 2 separate grants, one to the university partner and one to the CBO, in particular if the CBO says the administrative burden is too much for them to administer a subaward. And they've never done that before. This is the first time ever across the entire foundation. So it's not quite the same as what you're asking for, but I do think, you know, a good example of where in an ideal world, universities would just be better equipped to I don't want to be so disparaging in my term of not valuing, but, you know, to support their partnerships. And maybe we will eventually move to that place as well, but I think we have to, you know, put in place some stepping stones to get there.
Hi, thanks everybody for your great ideas and what you shared. I had a question for Daniel about your first goal that you mentioned. Caroline Fichtenberg from UCSF. Around health disparities, and I'm just curious if you could say more about how you're thinking about tackling these very challenging issues that, as you have mentioned, go much beyond the DPH and their programs.
So I will be very honest, as we've been going through that is the area that is the most challenging to figure out. Because if you look at, there's one view which is, let's look at what we're doing in the department today to tackle that. We have all sorts of programs funded in a range of different ways that try to go as upstream as possible. And some of them are on health-related social needs, like food as pharmacy, or we certainly do quite a bit on the housing, permanent interim housing space. We also have a number of grants that we work with community organizations. Rafiki was one of them, for all sorts of health access points across the city. On overdoses, we just released contracts for 2 community-based, culturally congruent organizations to tackle overdose and education and naloxone distribution, particularly for Black men over 50 in certain communities. So there are all sorts of examples of that throughout what the department does today. I think, though, when our teams, Chad, who are very passionate about this, the general sentiment is we are trying a lot of things. It is a thing that is beautiful in San Francisco, but our teams are not all convinced that we, with our community, really have a sense of how boldly we could go. And I keep saying to our team, and including Susan Phillip, our health officer, number one, we must not be the only place on earth really trying to think about how to tackle this. And even within San Francisco, we are not the only ones thinking about how to tackle this. And so there's quite a bit that we want to figure out how to structure. Some of that involves things that we would directly, programmatically support from a health standpoint. Everything from the right culturally congruent health access, which is kind of very near term but has preventative benefits. Some of it we've been debating from long term, what are other things we can do for adolescent and child health. I mentioned the preterm birth rates, but also a range of health outcomes and care delivery at the 0 to 12 years old stage that will have and maternal outcomes that will have long-term impact. But I think our team also feels pretty convinced we need to find some way in partnership with organizations in the community and community health workers to find a different way to engage individuals that are at risk for some of the areas and conditions we might put the most focus on, and find a way to activate that in a way that is beyond just the department. So for example, in certain zip codes where I want to know how many people, like numbers of human beings, are dying, for example, of certain cardiovascular disease above the population average in a particular zip code. That quantifies not just as a percentage, but the number of human beings that we need to be able to change how we collectively are supporting over the course of a long period of time. And then how do we organize a range of partners, local groups, healthcare, not just DPH, but other providers, other community-based organizations, faith-based organizations, others, to be tackling that with that level of goal of how do we get 50 fewer people dying per year that are, say, Black African Americans in this zip code from these things over a long-term trajectory. So that is a little bit of the goal seeking and also trying to quantify data-wise what that looks like. The actual interventions, I think we are deeply hungry for advice, support, and how do we empower and partner with the community to really, over time, make that happen.
Thanks. Thanks, everybody. We're done. Appreciate it.
Are we done? Laura, can I mention the rapid response really quickly? I feel I would be remiss to not say that it's open. So I'm thrilled that so many grants have been reinstated at UCSF. I know that there are many more that have not, and many that have been lost since our last round. So I will say that we currently have a round of rapid response funding available. If you have lost federal research funding, it doesn't need to be a research primary grant. It could be just a research component of a grant. And I know someone earlier on the stage had clearly applied and not received one of those grants, but we have over double the amount of funding available for this round, and I checked the number of applications this morning, and half the number of applications that were submitted for the last round. So I do think the odds of receiving funding are higher this round. They're obviously not guaranteed, but we have over $5 million for rapid response funding available. Applications are due October 1st.
Thank you.